today's talk, really I wanted it to be fairly practical for everybody. So hoping just to, really give an approach for male patients that we're seeing in our clinics, and then go through a little bit of the data and the evidence behind it when it exists. On the male side, we're a little bit further behind than the female side in terms of performing really well done, high quality research studies to have high levels of evidence. But we'll go through what's available and some of the conclusions that we can reach with that. So we'll start out with speaking to the history and physical exam, some of the evaluations, and then I'll go through my approach for interpreting some of the tests that we frequently order and some of the indications to order some of the more specialized tests. And then we'll spend a little bit of extra time focusing on the diagnosis and management of azoospermia and some of the hormone treatments and therapies that we can also try as well. So that's a bit of an overview. So as most of us in this conference probably know, the definition of infertility is the inability of a couple that is actively trying to conceive within 1 year if they're less than 35 years of age, and within 6 months if they're over 35 years of age on the female partner side. Infertility affects 15% of the population around the world, and male factors are contributing to about half of these cases. So it's estimated about 50 million men have infertility around the world when we do the math. Okay. So when we're taking a history, there's a number of important things to kind of focus on. And, there's a lot of different areas to kind of break this down. And a lot of the time it comes down to how you've already categorized history taking in your regular practice. But I think this is a fairly practical way from the Canadian Urology guidelines on azoospermia. And first of all, we want to know their fertility history. Is this primary or secondary? Have they never had a pregnancy either on the male or the female side? Or is it something that they have some children and something has changed in that interim that has led to difficulties with getting pregnant? So the duration, like I mentioned, primary or secondary. If they've had any treatments to date, it's important to know that and where the new starting point is as this patient's in your clinic. Another few questions that are really important to know about is their sexual function. These sometimes get left behind because we're really focused on sperm production, sperm quality from the male side. But sometimes there can be challenges with erections and ejaculation, and those don't always surface because men oftentimes aren't very comfortable talking about it. So I find it's really important to have a pointed question to ask about erections and ejaculation, just to ensure that things are working well. Another thing that I find quite frequent for patients coming through the clinic is, as couples are trying to be sexually active every day or every second day around the time of ovulation, it becomes a little bit less spontaneous, and there can be challenges with libido and erectile function that go along with that. So just something to be aware of, and they may need a little bit of assistance to help ensure that everything is working well in that department. Then we go and look at some of the general medical conditions that can contribute. Diabetes is one of the top ones and can have an impact on sperm quality, as well as ejaculatory function and erectile function. Respiratory issues, that's kind of get into some of the more, very unique and more rare cases. If there's history of cystic fibrosis, for example, we'll touch on that a little bit later, or if they have chronic chest infections, problems with cilia within the respiratory system, and cartilaginars or amotile sperm. Recent illnesses is really important, especially in the age of COVID right now. Certainly having a fever or being systemically unwell due to a viral infection, bacterial infection, or cancers can have a really significant impact on sperm production. So that's really important to know about, particularly if we only have recent semen analysis tests that may be within 3 to 6 months from a fever. Those can artificially be lower than their natural baseline. There's also a little bit of data that's mounting that COVID infections are potentially having a significant impact on semen parameters, and there's a higher frequency of azoospermia or severe oligospermia. So something to be mindful of, and as more and more data kind of presents itself, that will be become more clear what the associations are. In terms of genitourinary infections, certainly infections of the testicle or the epididymis can have a significant impact. Mumps orchitis or other forms of orchitis can create a lot of inflammation within the testicle and can have an impact on sperm production and sperm quality. There's a lot more free radicals and oxidizing agents that can damage the sperm membranes and the process of spermatogenesis. Infections of the epididymis can lead to obstruction, and those tubules in the epididymis can essentially scar down, and they can become azoospermic, or if it's only one-sided, that side could actually become relatively azoospermic, but their other side will hopefully continue to make sperm. So those are things I'm always paying attention to. If I have cases that present with azoospermia, it's not exactly clear what the etiology is. That's something that can play an important factor. Surgery of the reproductive tract. I kind of break this up in my mind anatomically. So obviously, if they've had surgery within the scrotum, I'm thinking, is there a chance of obstruction? It's been shown that about 15% of scrotal surgery, hydroceles, hernia repairs, etc., can have unilateral obstruction of the vas deferens or the epididymis on that side when it wasn't identified at the time. So that's always really important to be aware of. If they've had undescended testicles and have required an orchidopexy and bringing that testicle down, there's a significant amount of data that sperm production in patients that have undescended testes are typically lower, and certainly those pexing stitches have a risk of creating obstruction as well. If they've had a vasectomy, obviously that would be a hindrance to fertility, but sometimes just getting some of the details around that's really important. Varicocelectomies, what was the technique used? How long ago was this performed? Do we need to do another physical exam and ultrasound to reevaluate if there's been a recurrence or not? Now, in terms of medications, there's a lot of different medications that can have an impact. I find this is one of the areas that's a little bit more challenging, and especially as new medications are coming onto the market, there's never really great data, I find, in most cases regarding the impact. So I find oftentimes if it's something that I don't see regularly, I'll look them up and see what the consensus of the evidence is. Some of the key ones that are really important to ask about, number 1, 2, and 3 on the list is hormone treatments or steroid treatments. So this could be testosterone replacement therapy, or this could be steroids, such as somebody looking for fitness gains, something like that. Essentially, testosterone, when taken exogenously, is going to shut down sperm production in the vast majority of cases. So this is really important to know about. Usually, if it's a remote history, the testicle tends to bounce back from that and continue to produce sperm. But if it's in recent history, this can be a very, very major player. Certain antibiotics can have an impact on sperm production and parameters. Alpha blockers, these are common medications sometimes for hypertension or for treatment of voiding symptoms like BPH. A classic one is tamsulosin. And what it does is it relaxes the muscle in the prostate and the internal sphincter of the bladder and the prostate, and you can end up having retrograde ejaculation in the vast majority. So something to be aware of. 5-alpha reductase inhibitors, another class of medications, dutasteride and finasteride are 2 examples, commonly used for voiding dysfunction. They target the epithelial cells within the prostate, but some men also take it as a preventative thing for hair loss at a lower dose, and this can also have an impact on sperm production and quality. Essentially, it blocks the conversion from testosterone to dihydrotestosterone, and obviously we know hormones are extremely important in sperm production. Chemotherapeutic agents, very, very important if they have a past cancer history and chemotherapy use. Certain chemotherapies, like alkylating agents, are particularly bad for sperm production. So it's important, if at all possible, to know exactly what regimen they've had in the past. Another thing to know about chemotherapies is that it can have an impact on chromosome quality and aneuploidy of the sperm cells within 6 months up to 3 years after chemotherapy use. So typically we recommend that couples do not try to get pregnant with sperm that's being produced up to 3 years after receiving chemotherapy for risk of sperm aneuploidy. Radiation therapy can also impact germ cells as well as the somatic cells, particularly if there has not been shielding of the scrotum at the time of treatment. Narcotics, they can centrally suppress the hypothalamic function and pituitary function. So therefore, you can often have poor production of your gonadotropins, LH, FSH, and then, of course, testosterone as a result. Now, testosterone is the most important thing when produced intratesticularly to drive spermatogenesis. We often think FSH is, but in fact, testosterone is the most critical molecule that we're aware of, and FSH helps modulate that. So anything that acts to centrally suppress is not a good thing. Environmental exposures, heat is a common one that you can pick up on history. Are they regularly going in hot tubs or saunas, or have a job that has a lot of heat exposure? Also important. Certainly the mounting evidence about marijuana or excessive alcohol use is not a positive impact on sperm. Certainly if they have any family history or genetic histories contributing to infertility or other conditions, it's important. And a few things that I also find to be important to ask about, but didn't make the list here from the guideline, is if they've had any brain surgery, radiation. I also ask about puberty onset. Did they have delayed puberty? That can point me in a certain direction, perhaps Klinefelter syndrome, amongst others, or was it normal? Any other developmental abnormalities? Can they smell? If they can't smell, I'm thinking possibly Kalman syndrome or anosmia. And then another important question that I often lead out with is, how many children are they interested in having? If they say, we really just want to have one child moving forward, then sometimes I'm thinking, okay, well, if there's something reconstructible in this situation, great. However, if they really want one, perhaps an assisted reproductive technique like IVF or IUI might be in their best interest. If they want more than one, then we're thinking, well, perhaps we have to be a little bit cost effective here and see what we can optimize. So it's always a balance of the couple's wishes, of course, and their expectations and hopes for what they're looking to acquire. Now, another important thing to know, an infertility presentation is almost like a gateway to the overall picture of men's health. So we know that men that present with infertility do have a higher risk of mortality from epidemiology studies. There's been several studies that have shown this increased association. There's also an increased risk of having other multiple medical conditions. So in a few of the sources, 1 to 6% may have undiagnosed other comorbidities that haven't surfaced yet, but when they present to infertility clinic, they become more relevant. And then there's some specific conditions like testis cancer. Risk tends to be higher in infertile patients, and increased risk of multiple sclerosis, diabetes, hypertension, and a few others. So just things to keep in mind when you're evaluating patients, that this may be an opportunity to redirect them back to their primary care physician and potentially help with other chronic conditions. Now, with respect to the physical exam, obviously you have the patient come in the room and take an overall kind of assessment of their body habitus, virilization status. If they have very poor virilization, I'm thinking, okay, perhaps there could be something hormonal here. We should evaluate this a little bit closer. Gynecomastia could reflect increased estrogen to testosterone ratios and aromatase activity. So I'm thinking about that, or Klinefelter syndrome. Cardiac and respiratory exam. This is particularly important if they do not have any motility in their semen, because that could reflect an overall defect in their body's ability to have functional cilia in Cartaginer syndrome or Cartagers. So that's a very particular scenario. In the abdomen, I'm looking, do they have any scars in the groin or the abdomen, to make me think Could they have had surgery in the groin, hernia repairs that could lead to an obstruction in the vas deferens? If they had a retroperitoneal surgery, such as an RPL&D for testis cancer, or other pelvic surgery for colon or prostate or bladder, sometimes there can be a disruption to the nerves that signal for emission of semen and sperm or ejaculation. So that can have an impact in aspermia or retrograde ejaculation or failure of emission. So another area that I'm paying attention to, sometimes, patients will remember all these things, but sometimes these inguinal incisions, they may have happened when they were an infant and they may have forgotten about it, or they're unaware of it if they had undescended testes or they had a infantile hernia. So I do find that there is certainly value in looking yourself in addition to asking the questions. Scrotal contents, this is really the most critical parts of the physical exam. So what is the size of the testicle? Is it within the normal range, or is it much smaller than expected, which could reflect more of a developmental abnormality or a problem with sperm production? Another question I'm asking, is the epididymis normal? If the epididymis feels very dilated, then I'm thinking potentially obstruction, depending on, of course, the semen parameters. If it's very flat and smaller than normal, I'm thinking potentially there may be a sperm defect. This is, or sperm production defect. This is particularly important in azoospermic patients. If the hormones are kind of in the gray zone, and we'll talk about that specifically in a moment, but when it's not a very clear picture, in these cases, it can be very helpful making note of the testis size and the epididymis, if it's flat, dilated, or normal. Of course, you always want to verify, is there a vas deferens present, to reflect if there is unilateral or bilateral absence of the vas deferens. And then varicocele assessment. So these are dilated veins of the spermatic cord. And we want to know, in the standing position, are they enlarged? Then you'll have the patient lie down, consider re-examining them. Has this varicocele reduced? If the varicocele does not reduce in the lying position, then sometimes we're thinking in the back of our mind, could there be a retroperitoneal obstruction leading to this? And that would be an indication to do abdominal cross-sectional imaging if it does not reduce. Now, if you just examine the patient lying down supine, the chances are we're not going to identify a clinical varicocele, because all of that blood will drain more easily, and you don't have the column of blood dilating the veins when you're in the standing position due to the leaky valve. So that's really critical to perform all your varicocele examinations standing. Penile examination, usually I'm just checking, are there any significant abnormalities? Is the meatus in the normal orthotopic position? If there's a significant hypospadias, then it may be actually physically difficult to deposit the sperm to the right anatomical position on the female side. So that's also just important to be aware of in obviously unique circumstances, but nonetheless, not something you want to miss. Rectal examination, it's not very often that we're performing a rectal examination. This would very specifically be for a midline cyst with an ejaculatory duct obstruction. We'll talk more about that in a few moments, but really the transrectal ultrasound I find to be more helpful than a digital rectal exam for this. Now, in terms of investigations, all the patients will typically start with a semen analysis. If it's totally normal, then it's reasonable to stop with one. If there's an abnormality, though, I automatically repeat it. There's a lot of variability from test to test, and therefore it's really helpful to have at least 2 tests on hand before making any treatment decisions or further investigation. The hormone profile, the 2 most critical things are the total testosterone, which you measure in the morning because that's when everything is standardized to, and the FSH level. Beyond that, you could consider LH, prolactin, estradiol, and TSH, but those are less critical compared to the total T and the FSH. I typically do not order this for all men, but only if they have a concentration less than 10 million sperm per milliliter. And that's also consistent with most of the guideline bodies as well. Genetic testing, karyotype, and Y chromosome microdeletion. These are typically reserved for men that have sperm concentrations less than 5 million and are not likely due to obstruction. So if a patient comes in with a vasectomy, they're azoospermic, it's not typically something that we order, particularly if they have previous paternity. So those are some of the kind of core testing that are based on algorithms and truly really based on the sperm concentration with the hormone profile and the genetic testing. Now, some of these other more specialized testing are situation specific. So DNA fragmentation is getting a lot more interest as the years progress here. And there's certainly a lot of controversy over the indications that it's used in. I think the most key indications where it probably has the highest value is if there's recurrent pregnancy loss, 2 or more pregnancy losses to the couple's history, idiopathic infertility where we don't have a good explanation despite normal semen analysis parameters, or if they're having recurrent failure of IVF cycles. I think these 3 are very reasonable considerations to try for DNA fragmentation. CFTR testing, this is another genetic test that's indicated if there's absent of a vas deferens on one side or both sides. Now, if this is positive or abnormal, then you always want to test the partner as well. And this basically gives the couple an idea of their risk of having a child with cystic fibrosis. Now, this is a little bit ethnicity dependent. Cystic fibrosis is more common in Caucasians or individuals of European descent. So the likelihood of having a positive test does decrease in certain different ethnicities. There's over 1,500 CFTR genes and mutations of the genes that have been described. And usually the panels that are ordered may only test 90 to 100 genes. So it's never a completely verifiable test, but it's testing for the majority that, let's say, cover 90% frequency and usually Caucasians, at least in North America, although the panels may be different in different parts of the world. So just something to perhaps communicate with your local lab that's performing these tests. Scrotal ultrasound, it's one of these tests that is so easy to order and frequently used, but it's probably also overused in a lot of circumstances. I particularly use a scrotal ultrasound if I find the physical exam to be difficult. So the skin is really tight, the scrotum, it's difficult to assess the spermatic cord or the testicle. Or of course, if I feel a testicular mass, then I want to investigate it further. One trick that Dr. Mark Goldstein frequently uses in his clinic is having a little heating pad. And as a patient checks into the room, a heating pad is just transiently over the scrotum for 5-10 minutes, which shouldn't have any impact on sperm production. And it really helps relax the dartos muscle within the scrotum. So the testicles are very easy to examine and can help optimize that. And then finally, the transrectal ultrasound. This is really reserved for patients that have low volume ejaculate, so usually less than 1 or 1.5 cc's, and they have palpable vas deferens in most cases. They have normal testosterone, and usually their fructose in the semen is low, and their pH may also be low, less than 7.2. And they typically have azoospermia or severe oligospermia. And usually if that's the case, their motility is really low. But we'll talk about that as well a little bit more in depth. But this can be very helpful to look, are the seminal vesicles dilated? Are they hypoplastic? And is there a cyst or signs of obstruction within the ejaculatory duct within the prostate? So that's the condition that we're thinking about that. And then a post-ejaculatory urine analysis. We typically perform this again in that low volume ejaculate, less than 1 or 1.5 cc's when they have palpable vas deferens. And we'll do this prior to doing a truss because the truss is more invasive, as you can imagine. Now, in terms of semen analyses, you want to have approximately 2 to 3 days of abstinence is where everything is normalized to. Essentially, the andrologist will look at a small portion of the semen under a microscope, identify and quantify the number of sperm that are there, what they look like for morphology, the movement of them, what number are alive. They'll also comment on the volume of the semen, oftentimes the pH, and in certain circumstances, they'll comment on number of round cells or presumed leukocytes, as well as any other kind of specialty testing within that. So like I mentioned, start with one. If it's abnormal, I would automatically repeat a second test. And I usually ask them to space it out at least a few weeks to 4 weeks, just to make sure that you're getting a different data point. Now, most labs currently are using the 2010 World Health Organizations. I find it's also often helpful to know, where do these numbers actually come from? Well, this is kind of the leading study that derived these numbers, these normalized numbers. And basically, they performed a study where they collected semen samples from 4,500 individuals across 14 countries around the world. They had several different groups in the study, but for the derivation of these normal values, they took fertile men, where they defined these men as the men of couples where the time to pregnancy was 12 months or less. Then they looked at what the normal distribution of the semen analysis parameters for each of the different parameters, and then they drew a line at the bottom 5th percentile and defined that as the normal limits. So if we look at the actual data from the paper, this was this group of men, and you can see on the left side, there are the different semen analysis parameters. And then on the columns along the top, this is the percentiles, and then the number of patients in each of these percentiles. So as you can see, this is the 5th percentile of this distribution of data. And that's how we arrive at 1.5 milliliters as normal or above, 15 million sperm or better, 39 total number of sperm. Total motility was 40%, and this was essentially the progressive motility as well as the non-progressive motility. And then they had a specific threshold of 32% for progressive, 4% strict criteria for normal morphology, and then the vitality or viability, 58% of the sperm should be viable and living. So this is where they have been derived from. But keep in mind, that means that 5% of all these individuals that still get pregnant within 12 months or less have semen parameters that are less than each of these things. So it doesn't mean that the individual will be infertile if they're under this, but the vast majority, 95%, are above. Now, one important thing to keep in mind is that there is a lot of variability in semen parameters. So this was an interesting study where they took 12 individuals and they did just about monthly semen analyses over a 1-year period. So for the 12 men, they had just under 100 semen analyses. And what they found, if you look at the graphs here, each of these letters represents a unique patient, and each of the bars within the letter cluster represents a different semen analysis. This top graph is sperm concentration, and then this bottom one is progressive motility. And what you can see is there is a really big variability in these two as just as examples. And if we look numerically at all the results, you can see that the volume varies by a factor of 1.9. So anywhere between 1.3 to 4.2 fold change in any one individual. Concentration varied on average by nearly a factor of 5 from the lowest to the highest within the same individual. Progressive motility, same thing, just under 3-fold, and normal morphology, just under 2-fold. So when we're interpreting these things, and I often find a lot of couples come with some anxiety if they have a few different sperm tests, and perhaps the most recent one was much lower than the previous ones. Most often, unless there's a good explanation for it, this is probably simply reflecting natural biological variability in our sperm production. Another important thing to know is that there's also an abundance of data that shows there's a significant inter-observer variability in semen analysis parameters. So meaning that there's differences between people within a lab, differences between labs. So it's a good test to give you directions, but certainly there are some challenges with the semen analysis, and always just kind of keep that in the back of your mind, that we have to interpret the semen parameters kind of from a big picture perspective, and precise details sometimes aren't quite as important. Now, as you were mentioning, this is kind of the first test that really tells us what our next moves are in either investigations or treatments. Now, there's a lot of different ways to work with interpreting the semen analyses, and I'll just kind of run through my algorithm of the numbers I first look at and how we deal with them. So concentration is usually the most important thing in my mind when I'm first looking at a semen analysis. And because the main thing is it tells us what next test we need to order. So like I mentioned in that earlier table, if the concentration of sperm is less than 10 million, then that is our threshold to say, okay, hormone profile, we're getting a morning testosterone level and an FSH for sure. And then we can consider estradiol, LH, prolactin, sometimes TSH. So that is the one threshold. And then certainly if the sperm concentration is less than 5 million, and we think there could be a sperm production challenge, then we're also considering karyotype and Y chromosome microdeletion. Now, this number may get revised over time. Some of the more recent data is suggesting perhaps a threshold more around 2 million or 3 million, maybe still selective enough that we're not missing very many cases where there could be an abnormality, but most of the guidelines still say about 5 million. And then certainly if the concentration is zero, either azoospermic, then I also really want to look at the volume. I want to look at the fructose and the pH level, as that's going to plug into our algorithms for azoospermia evaluation. We're going to talk about that too. Now, most of the individuals in our crowd today probably know some of this stuff even better than I do, but I often like bringing this back and talking about some of the typical thresholds that you need for assisted reproductive techniques as it relates to semen analysis parameters. So for IUI, typically we're looking at 5 million post-wash total motile sperm count. There's a recent paper published within the last few months here suggesting 7 million might actually be the most optimal threshold, but certainly some labs around the world are even able to do IUI with lower numbers. Just the success rate per trial of IUI might be a little bit lower as the total motile count decreases. Classic in vitro fertilization, generally we're talking around 50,000 sperm. And then of course, IVF ICSI, obviously we need 1 viable sperm per egg. So we really don't need very many sperm to overcome most cases of male factor infertility. Now, when we're looking at the motility, it reports total and progressive. I'll often look at both, and the total is, quite helpful to look at initially and then see if there's a big discrepancy. The next thing I look at when I see a motility is the vitality or the viability. If the motility is low, but the viability is also very low, then we have an explanation. Well, they're not motile because they're not living. So something is damaging the sperm, or another factor is involved that's harming them or killing the sperm, and that's why they're not motile. However, if the viability is very good, but the motility is really low, that's telling us the sperm are living, but there's a problem with the motility, and that could be an intrinsic sperm problem, or it could be an extrinsic problem like anti-sperm antibodies, for example. So if it's really, really low, there's a few things I'm thinking about. If it's near zero, I'm thinking, is it Cartagener's or Cartagener's syndrome, where it's a primary defect of the cilia and the inability for the sperm to move? Is there anti-sperm antibodies? This is highly associated if there's been previous obstruction in the reproductive tract for men, up to 81%, or 10% can be idiopathic. And depending where these antibodies are binding, it can inhibit the ability of sperm movement. Axonemal defects, these can be mid-piece defects, or these can be tail defects, and then there's subclassification within that, dynein arms, it could be the central microtubules or some of the peripheral couplets. And really the only way to kind of diagnose this is if you have electron microscopy of the sperm tails. Really, only select centers in the world have this. In Canada, to my knowledge, I think only Toronto has access to this. And really, it doesn't change clinical treatment so much, because most of these patients that have very, very low motility will probably end up needing IVF-ICSI. But if you do have the information, then perhaps there's less of a chance for modification, as there's only one study that I'm aware of that tried antioxidant testing and treatment with L-carnitine that had a statistically significant improvement, but I would argue was not clinically significant. So this is typically untreatable. If there's any sperm antibodies, we're still kind of looking at IVF-ICSI. But importantly, when you're seeing patients, you want to look at the history and physical exam. Is there something modifiable that we can change the motility? And that's often the job of the male factor infertility specialist. Are there heat exposures? Is there varicocele? Are there other medication exposures, recent infections, etc., that we can manage? Now, morphology. Knowing that the normal morphology rate is 4%, that means 96 of every 100 sperm have some problem with them. So we're pretty tough on the sperm. It's a tough life for a sperm to be in the perfect category. And I find this category on the semen analysis is the most subjective. And we know that there's a lot of variability from andrologists to andrologists that are interpreting these results. And it's less predictive in fertility than it is with progressive motility, total sperm counts. So I put the least weight on these, except in unique circumstances, such as pinhead sperm, where there's no genetic content, or Azoospermia, which are the big round-headed sperm and often are associated with genetic defects, many of which have been described so far in the literature. So these two circumstances can be very difficult to manage, even in the presence of IVF-ICSI. Of course, if there's no DNA content, it will not result in a fertilization. And these can also be problematic with Azoospermia. Nonetheless, in more typical cases of abnormal morphology, we're looking again to history, physical exam. Are there any reversible factors contributing to this? And then, of course, not everything in medicine comes perfectly binned into individual abnormalities. There can be combinations of abnormalities. If we have all of the abnormalities with motility, count, and shape, then we have this term OAT, or oligoasthenoteratozoospermia. And this is unfortunately a not infrequent finding that we have, but this is classically associated with varicoceles. So when I see this semen analysis parameter coming through the desk and I'm about to meet the patient, I'm going to be sure to examine them for a varicocele to see if this is contributing. Of course, that's not the only thing that can contribute. Medications, poor lifestyle, other findings on physical exam can also contribute. Now, I'll talk a little bit more about varicoceles. They're actually very common. About 15% of all men have a varicocele, and whether it causes any abnormalities or not is very individual specific. But we do know that in men presenting with primary infertility, about 35 to 45% will have varicoceles. So certainly there is an association there. And then secondary infertility, so they've had a pregnancy or a child in the past, and now they're having problems with infertility. 45 to 81% will have a varicocele. So that's also very high up on my differential in my mind as I'm meeting an individual that has a child and they're looking for a second, and now all of a sudden it's more of a problem. And the reason that we think this is we look at varicoceles as this condition that is constantly causing some progressive abnormalities to the testicle. So slowly over time, it's creating a less favorable environment for sperm production and sperm quality. And that degree of dysfunction accumulates over time. And therefore, if it's been 5 years, 6 years, 10 years since their last fertilization and pregnancy, well, it may have accumulated more damage to that testicle that has a varicocele in that time period, and therefore now they're having troubles versus before. Of course, the female age is also contributing in some of these circumstances where it's secondary infertility, but it is an interesting association. Now, when we're talking about varicoceles, we're really talking about clinically significant varicoceles. So you can find a varicocele with a Doppler ultrasound, and if you can detect it there, but you cannot palpate it, this is what we call as a subclinical varicocele. And most of the literature would suggest that treatment of these is not clinically meaningful. So really, we're only treating these varicoceles grades 1, 2, and 3 when we can feel them. We grade 1 varicoceles as only being able to palpate it when the patient is valsalva in the standing position. Grade 2 is it's palpable even when they're not, so they're just standing there and you can feel it. And then grade 3, you can see it just looking at the skin. It looks like a bag of worms on that side just above the testicle. Now, there's many different kind of theories and hypotheses of how varicoceles can impact fertility and sperm production. I thought this was a particularly nice overview and flow chart from this group that did a very nice review on varicoceles. So we have this finding. We know that we have a column of blood and the valves are not functioning well. So that column causes increased hydrostatic pressure as the venous blood is refluxing down towards the testicle. That results in the scrotum being warmer. There's been studies that have done temperature assessments of the scrotum, and they tend to be about 1.5 degrees warmer with a varicocele compared to with no varicocele. So this is a finding. Hypoxia, there's less arterial blood coming through because there's increased hydrostatic pressure, and therefore it's more difficult for the arterial pressure to get through the capillaries and make its way into the venous system. And then, of course, the whole purpose of venous blood is to get back to the heart and to the lungs and to get cleaned out by the liver and the kidneys and oxygenated. And if that's more difficult to do, then all these metabolites are going to be building up. And we think that the accumulation of all these things lead to oxidative stress, which is a common thing that we talk about in male reproduction and likely in female side as well. This results in increased reactive oxygen species and a decreased overall total antioxidant capacity. So the end result is that we have impaired testicular function. Now, there's a lot of data about varicoceles, and unfortunately, as I mentioned at the beginning of the talk, there's not very many randomized controlled trials that we can draw data from. A lot of it is case series and retrospective analyses. So we have to take the data with a bit of a grain of salt, even when we do a meta-analysis. Of course, if we do a meta-analysis of low level or poor quality data, then we cannot arrive at a very high quality result. We're still burdened with the fact that the input data to the meta-analysis may be a little bit problematic. That being said, with the meta-analyses, it suggests that varicoceles improve spontaneous pregnancy rate, decrease miscarriage rate, increases live birth rate in men that have low sperm counts, increases clinical pregnancy rate if they have azoospermic. Well, that's a little bit controversial. The most recent AUA and ASRM guidelines does not recommend performing a varicocele repair in an azoospermic individual. Varicocele repair increases sperm retrieval rate in azoospermic men. Again, these 2 points are a little bit controversial. It usually does increase serum testosterone levels by a few hundred points if we're using American units, and by 1.5 to 2 points in metric units. It also can improve the clinical pregnancy rate with IUI if it's starting with a individual that has a low sperm count, but it doesn't help all individuals that have infertility that are undergoing IUI. So it's probably mainly a sperm number thing here. On average, it also improves the motility, morphology, and concentration if you're looking at the endpoint of a semen analysis. This is perhaps the least important because really our end goal are live birth rates. But that is something that on average happens, although it is very difficult to predict for any one individual patient that's coming through. Sometimes we'll have very big improvements for some, sometimes we won't have any improvement for others, and then of course everything in between. So it's this is helpful from a population basis, but sometimes less helpful in counseling the individual or the couple in front of you. And then, one of the goals from the male perspective is if we can do something that's reversible, like a varicocele repair, can we lessen the invasiveness of the necessary assisted reproductive technique that's required? So can we take them from a range that they have to do IVF to then all of a sudden having more sperm numbers and being able to do IUI successfully? So that's a potential benefit. Now, varicocele repairs aren't the right choice for everybody. Certainly if there's advanced female age, we know that it's going to at least take minimum 3 months, but realistically 6 to 9 months by the time you schedule the varicocele repair. They wait 3 to 6 months for 1 or 2 full cycles of spermatogenesis to occur before we really realize the benefits. So this can delay treatment in some individuals, and that might not be the best bet for them. And then, as we mentioned, if you cannot palpate the varicocele in an appropriate physical exam, then that's often not going to be helpful. So what do we do if the semen analysis is normal, but they still have unexplained infertility, and everything else has been normal? Well, like I mentioned, this is one of the indications that we could consider DNA fragmentation testing. So a summary again, we tend to do DNA fragmentation testing if there's recurrent pregnancy loss, repeatedly failed IVF or IUI, or if they have idiopathic or unexplained infertility. And certainly some groups are more liberal with ordering this and have a greater range of indications. But this is kind of what makes sense with me, and it's in alignment with the AUA and ASRM guidelines. Now, interestingly, about 30% of men that are evaluated through a fertility clinic will actually have elevated DNA fragmentation. So it's actually a little bit more common than one might anticipate. Now, there's a few different theories of how do you arrive at DNA fragmentation? What does it mean? Well, one of the theories is that you have inadequate protamine exchange for the histones in sperm compaction of the nucleus. So during spermatogenesis and spermiogenesis, after meiosis too, you end up with a haploid cell, and the DNA is bound around histones at that point. And then as you go through spermiogenesis, where the round spermatids are going into the elongating spermatids and eventually into a full-grown sperm, that DNA gets repackaged around protamine proteins that compacts it really, 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 really tight. And that tight compaction allows the sperm head to be much smaller, but it's also not very accessible for transcription, which it doesn't need to be. But it also makes it more bulletproof or more resilient to oxidizing treatments, free radicals, those kinds of things, which is important for sperm. So there's been some studies that show those individuals with high DNA fragmentation actually don't have as much protamine in the center of the DNA compared to the histones. Now, during this process where the chromatin's getting repackaged, the natural physiology and biology is that the DNA needs single and double strand breaks in order to unwind it and then exchange the protamines. And normally the polymerases and other structures go in and fix the single and double strand breaks in the DNA. But if there's a problem with DNA repair, then some of these single and double strand breaks no longer get repaired, and you accumulate more and more and more during the process. That is a normal physiologic process, but if you're not repairing it properly, it can become a problem. Another theory is that some of the cells undergo partial apoptosis or cell death. And when that occurs, there's a lot of reactive oxygen species and free radicals that get produced that can damage cell membranes and DNA. And then the other thing is the post-testicular environment. So in the epididymis or the vas deferens and the reproductive tract, if it's met with a lot of reactive oxygen species, the sperm can become damaged from these. And one of the things that is very suggestive of this is that if you take testicular sperm from the same patient that has elevated DNA fragmentation in the semen, it's often 2 to 3 times lower. So that suggests to us that freshly produced sperm in the testicle don't just come out with high DNA fragmentation, they come out with pretty normal DNA fragmentation, and then it accumulates over time. So that's either because the environment around it is not very ideal and it's damaging the sperm, or those sperm are very susceptible to damage even in a normal environment, which are more the earlier theories compared to this most recent one. So anyways, very interesting. We'll have to see, you know, as the science progresses with this, if we can nail down a little bit more to the actual mechanisms that we're seeing. Now there's several different DNA fragmentation assays. For the most part, they perform pretty similarly, despite being very different assays and to be honest, measuring slightly different things altogether. So sperm chromatin dispersion assay, SCSA is a very popular one. Comet assay, there's an alkaline comet assay, and then tunnel assay. Of the studies that have done some comparisons, perhaps the comet assay or the alkaline comet assay is one of the more predictive ones. And then there's also been some votes for tunnel, but oftentimes it's what's accessible to your local institution to perform one of these assays. Now, we know that individuals with increased DNA fragmentation have increased risk for miscarriage. They have reduced embryo development, and there's potentially reduced fertilization. So with that information, is there anything that we can do about it? So one is trying to, you know, identify all reversible factors from the environment. So potentially heat exposures and obviously treating infections, that kind of thing. Is there varicocele that needs repair? If there's something that's addressable, or smoking, for example, then fantastic, address that, retest. If not, and we're considering going to IVF-ICSI, then becoming more popular is the use of testicular sperm. And as I mentioned, the testicular sperm has much lower DNA fragmentation compared to ejaculated sperm. And although it has slightly lower fertilization rate, those embryos that are created have a much higher likelihood of resulting in overall increased live birth rates and decreased miscarriages. So I believe our next slide, we're going to go into that. Yeah, so here there's a Semen Analysis performed by S. Steves and some of his colleagues in 2017, and they included 5 studies. And basically they were looking at individuals that had IVF-ICSI failure, and they had idiopathic infertility. So we really didn't know why, but when they did the DNA fragmentation, it was increased. And what they found was that when they used testicular sperm, we had lower DNA fragmentation with the same assay. So just under 9% compared to 33% as the starting point. So that kind of adds fuel to the fire for our theory of going to the testicle. As I mentioned, the fertilization rate was lower using testicular sperm, about 60% versus 70%. But the clinical pregnancy rate was higher, is 50% versus 29%. The miscarriage rate was lower, 9% versus 29%. And then ultimately, the most important factor is the live birth rates were higher, 47% versus 26% using the testicular sperm. So certainly, the bottom line with this is that there's not a lot of data. It's there's certainly biases within the data that's being published. The other really important thing is this group of patients have already failed. So we're going to have some regression to the mean here because we've had the recruitment is because they failed IVF. So really they can only fail again or they can improve. And therefore improvement would be a regression to the mean. And therefore I think there's likely some of that bias within the data that we're seeing here. That being said, much like most of the data that we have in the male infertility world, it is retrospective, but of this available data, this certainly is a positive outcome. So it's something that we certainly consider. It's more, I'd say, on the periphery of evidence-based medicine, but there certainly is some mounting evidence for this. So it's an interesting consideration. Okay, so let's transition to azoospermia. This is often one of the more diagnostic pathway algorithmic sections of the male infertility world. And there's sometimes some anxiety around, sorting out what's going on. And in most cases, hopefully we'll communicate today that it's fairly algorithmic and stepwise. And at the end of the day, there's still some gray areas that may require diagnostic biopsy, but for the most part, we can do without that. So definition of azoospermia is that there is no sperm in the semen based on 2 semen analyses that have been centrifuged to look at the pellet and ensure that no rare sperm are being missed. So once you have that, we tend to break it into normal volume azoospermia or low volume azoospermia. That's one important branch point in the algorithm. The other is the FSH and the testis size together. So if the FSH is really high, that's usually indicating that the testicle is not working well. The brain is sending extra signal, so it's yelling louder for the testicle to make sperm, but the testicle is too inefficient, it's not functioning well enough, and therefore it's not producing sperm despite lots of signal from the brain. Now, if the FSH is normal, then I'm thinking probably more of an obstruction because the testicle seems to be functioning properly from a hormone standpoint. Certainly if the FSH is nearly undetectable, then I'm thinking more central. This is now a problem that the hypothalamus or the pituitary is not functioning properly, so it's not sending enough signal to the testicle who needs that signal to make sperm. So this fits in nicely with our previous rules. If you remember, whenever there's a total or a sperm concentration less than 10 million, we're ordering a hormone profile. So you already would have caught this even with the 0 sperm count. And same goes with the rules for the genetic screening. Total sperm count is less than 5 million. So therefore we would be ordering the karyotype and the Y micro. Now this should be ordered again when we think there could be a production problem. If there's an obvious cause of azoospermia, such as vasectomy or other obstructive cause, then we don't have to order the genetic testing. But in cases where we're unsure or it's more of a production problem, then we should order it. Now, the karyotype, the most common karyotype abnormality is Klinefelter syndrome, defined as at least one addition of an X chromosome. So 47XXY is the most common classic karyotypic description of Klinefelter syndrome, but there's a lot of variability. There can be multiple X's. So it could be 48XXXY, 49XXXXY, and there can be mosaicism and more subtle abnormalities as well. Obviously, classic is 46XY for a male, but you can also have other things like mixed gonadal dysgenesis, where they have combination 46XY, 45X. You can have translocations. These can be Robertsonian versus not. There could be marker chromosome segments. There can be deletions. There can be gains. So there's a lot of different ways a karyotype can be abnormal, but the vast majority are Klinefelter syndrome in this particular circumstance. I'm just going to take a drink. Now, the Y chromosome microdeletion, this is also important. Let me just make one more comment about the karyotype. Karyotype is abnormal in roughly 7 to 8%, where Klinefelter syndrome makes up about 7.5% of those abnormalities. Now, this Y chromosome microdeletion, generally there can be, this refers to a deletion of a specific region on the Y chromosome. We know that this region on the Y chromosome is important in spermatogenesis and contains many of the genes critical to sperm production. And this is called the Azoospermia factor, the AZF region. Now, this AZF region refers to an A region, a B region, and a C region. And so these are 3 separate areas, although there's a little bit of overlap between 2 of them. And if there are complete deletions in each of these, then the results are typically pretty characteristic and predictable. So if it's an AZF-C deletion, then there can be sperm. So I remember this by being a C, you can see sperm. And then with an AZF-A or B deletion, A is awful, B is bad. In those, if there are true complete deletions, then there's no chance of finding sperm. Exceptions to this are if there are partial deletions in the A or B region, then it's still possible to have sperm production that's retrieved either in the semen analysis or on microtesty. Part of the challenge is that it really depends how the lab is performing this. Most of the labs evaluate Y chromosome microdeletions through PCR testing for particular probes. And if the probes aren't covering the entire region, then you may think it's a complete deletion, but in fact, it's not testing some of it where there could be genes present, and therefore it may ultimately be a partial. So that's just something to be aware of. And sometimes it's helpful just to know what your local lab is, how they're doing this, to know how confident you can be when you receive a result. Is it truly a complete deletion or a partial? So if it's a true complete deletion with the A and the B, then we do not recommend trying surgical sperm retrieval through a microtesty, as there's never been a reported positive retrieval. But on the AZF-C deletions, there certainly can be. Now, the CFTR testing, as I mentioned earlier, really we only test this if there's an absence of the vas deferens on one or both sides. Sometimes if there's ejaculatory duct obstruction, some practitioners have ordered this as well. Okay, so let's start. Remember I said when we see azoospermia, I first break it into, is it a low volume problem or is it a normal volume problem? So if we break it into the low volume azoospermia, this is how I will kind of go through algorithmically in my mind. So first questions on history. I always ask, is this a very typical semen analysis or semen production for you? And sometimes they'll say, no, I felt really uncomfortable. It didn't come out naturally, or did you miss the cup? Sometimes that will happen. Or on history, picking up that there's just failure of emission. Do they have a spinal cord abnormality? Have they had a retroperitoneal surgery that could lead to failure of mobilization of the sperm to the semen and the urethra? Those are things that really you're picking up on history, almost most importantly, and you're verifying with the semen analysis, but really important to pick up right off the bat. Then I'll move on to the physical exam. So the first question, are the vas deferens palpable? If they are palpable, then I keep looking further on the semen analysis. We'll go to that in a second. If they're not palpable, then we're doing the CFTR testing, that genetic test. If the testing is abnormal, we have to do CFTR testing on the partner too, because cystic fibrosis is autosomal recessive. Having abnormalities on both parents drastically increases the chance that their child can have cystic fibrosis as well. If their cystic fibrosis testing is normal, then the explanation for why one or both of the vas deferens is missing is likely a developmental anomaly due to problems with the Wolffian duct developing. And because the testicles originate near the kidneys in the abdomen, and through fetal development, they descend down through the abdomen, through the inguinal canals and into the scrotum. Abnormalities with the vas deferens can also reflect abnormalities with the kidney. So we get an abdominal ultrasound, and 50 to 75% of the time, there's some abnormality or agenesis on the same side of the abdomen that a kidney may be missing, or pelvic kidney, malrotated kidney, etc. So anyways, just something important to also do. Okay, let's look further at the semen analysis. So if we look back up here, if we can palpate the vas deferens, then we want to look more at semen analysis. So we drop down. The next questions after I see low volume azoospermia is I want to look at the pH and I want to look at the fructose. So if the pH is low, so it's acidic and less than 7.2, then that's telling me the seminal vesicles probably aren't contributing fluid components to the semen here, because that contributes alkaline fluid, where the prostate contributes acidic fluid. So if we're only getting acidic fluid coming out, then there's probably a blockage behind the prostatic contribution, and therefore the seminal vesicles are not contributing the alkaline to balance it out. And I'm thinking there's a blockage probably at the ejaculatory duct or at the level of the ampulla of the vas, where the sperm and the semen from the seminal vesicles are joining and not able to make it into the prostate. So acidic pH, we're thinking ejaculatory duct obstruction. And if the fructose is absent or very low, then I'm also thinking ejaculatory duct obstruction. The fructose is produced in the seminal vesicles. And again, just like the alkaline component, if it's not getting through, you're going to have an acidic semen and you're going to have an absence of fructose. And that's going to tell me this is much more likely to be an abnormality with an ejaculatory duct obstruction. So if these are abnormal, so no, they're not normal, then we do a transrectal ultrasound to look for this obstruction. If the pH in the fructose is normal and we just have a low semen volume, then our first move is to perform a post-ejaculatory urine analysis, and we want to test the serum testosterone. Low testosterone can contribute to lower volume semen, and certainly if it is going backwards, when the individual ejaculates, instead of it coming antegrade through the penis, if the internal sphincter where the bladder meets the prostate is lax, then it can go backwards into the bladder and not come out. Okay, so we'll talk a little bit more about that, retrograde ejaculation. So as I was mentioning, we typically diagnose this on a semen analysis, or we suspect it. To determine if this is actually happening, we'd get them to perform a semen analysis, and then we'd have them immediately void after performing the semen analysis, and the laboratory technician would centrifuge down the urine to look for the concentration of sperm cells in the pellet. Oftentimes there's going to be a handful of sperm cells just because of the urine coming out through the urethra, and it's going to pick up some of that. But if there are vastly more in the retrograde sample compared to antegrade forward, then this is telling us it's most likely retrograde ejaculation. Now, for just the diagnostic test, you don't have to do anything fancy with alkalinizing the urine or using any other medications, etc. But that will give you the diagnosis. Now, if the causes of this can be an incompetent bladder neck, this could be because the prostate's getting bigger with BPH. It could be a nerve problem, such as a peripheral neuropathy with diabetes. It could be due to medications, as I mentioned before, like the alpha blockers, the antihypertensives in that class, or tamsulosin, which is used to treat BPH. So those are the most common things. Now, to treat it, you can try them on a sympathomimetic like Sudafed or pseudoephedrine. And basically, this causes the internal sphincter of the bladder to tighten up, and it will promote antegrade ejaculation. Usually, I'll recommend using 120 milligrams 2 to 3 hours prior to ejaculating, and we'll evaluate if this changes the volume of the semen, and then test again to see if there are now sperm in the semen. There are some other agents that people have tried as well, and there's also different regimens, such as taking a smaller dose of Sudafed or pseudoephedrine daily for 2 or 3 days prior to producing a sample. Now, if this is impossible and we can't get them to ejaculate forward, then we need to harvest the sperm. So to do this, we can pre-alkalinize them. So we get them to take some sodium bicarb or Alka-Seltzer tablets the night before, which will bring more bicarb and basic media into the urine the following day. And then we collect the urine either by having the patient void immediately after ejaculating, or they can do an in and out catheter if there's a problem why they can't do that, such as if they have a specific spinal cord injury or something like that. And you can harvest the sperm that way, immediately wash it, put it in sperm buffer media, and then you can use it for intrauterine insemination or IVF. So that is the approach for retrograde ejaculation. Now, if they have failure of emission or ejaculation, let's first just talk about the difference between emission and ejaculation. Emission is a transport of sperm to be delivered into the urethra, and ejaculation is the process of evacuation of the seminal fluid in the urethra to outside of the penis. Okay, so failure of emission is perhaps more common than failure of ejaculation in situations where there's retroperitoneal surgery, like an RPLND for testis cancer or some other pelvic injuries, sometimes with spinal cord injuries or surgeries as well. So, like I said, this is often diagnosed on the history, and we've ruled out retrograde ejaculation. So they are achieving an orgasm or ejaculation sometimes, but we still don't see anything, then it's probably a failure of emission. Or if they just cannot simply achieve orgasm or ejaculation, then it's a failure of this as well. So what we can sometimes try is penile vibratory stimulation. This is more often used if they cannot achieve orgasm and ejaculation, such as in a spinal cord injured patient. And if this can generate an ejaculate, then that can be used for insemination, IUI, or IVF-ICSI. In the case where they've had pelvic nerve damage or spinal damage or injury, then you can move forward to electroejaculation. And if they're a candidate for penile vibratory stimulation, you'll start there, it's less invasive. And if they fail that, or they're not a candidate for penile vibratory stimulation, we go right to electroejaculation. Here, there's a probe that's placed into the rectum. If they have sensation, you do this under a general anesthetic, and you apply current that will stimulate the nerves and the muscles in the pelvic floor to cause an artificial emission or transport of the sperm and semen into the urethra. And then that will either come out antegrade, or if it goes retrograde, you'll catheterize them at the same time and collect the sperm that way. If we're doing that, usually what we'll do is we'll drain the bladder from the urine. You'll put in some sperm buffer media, and you'll use something like a mineral oil to use as lubrication to put the catheter in and out, rather than a traditional lubricant that you'd generally use for catheter insertions. And that's just important for maintaining good health and viability of the sperm. So this will work in high 90% of all individuals that have failure of emission. But certainly if they're not a candidate, if they've had rectal surgery where they no longer have a rectum or an opportunity to place the probe next to the prostate, then another option is surgical sperm retrieval. So you could do this either with a needle or a biopsy, and you can either retrieve it from the epididymis or directly from the testicle. If we go down this pathway, then we're committed to IVF or ICSI. So that's typically the algorithm. Start less invasive, go more invasive as necessary or as the previous treatments have failed. Okay, we're going to transition now to normal volume azoospermia. So here we're really trying to work out, is this a blockage problem or is this a sperm production problem? Okay, so another way of thinking about it is a level problem. So is this a brain problem, hypothalamus or pituitary? This would be improper hormone production of your gonadotropins, LH, FSH, etc. And that's a level, and therefore it's a sperm production problem. Is it a testicular problem? So the testicles just aren't responding well. So those hormones are high, the brain's working well, but the testicle isn't. Or is it a post-testicular problem? So sperm production is normal, but there's a blockage somewhere. That could be in the epididymis, the vas deferens, or the ejaculatory ducts. So that's just another way to think about it. Now, this is typically the algorithm that I will work with when I see a patient and I'm thinking through it in real time. So we have two semen analyses that show azoospermia, and they have normal volume. I'm looking at their hormones next. What is their FSH? If their FSH is high, so that's telling me, well, it's not a central problem, it's probably a testicular failure problem. So then I'll examine their testicles and the epididymis. So the most classic scenario here for testicular failure is high FSH, smaller testicular volume, and this is now non-obstructive azoospermia, NOA, due to testicular failure. This is quite classical, and we'd move forward if they're interested with surgical sperm retrieval with microtessi, which would be the most common approach. Now, if their testicular volume is normal, it's still probably testicular failure, non-obstructive azoospermia. But if this FSH is only mildly elevated, normal testicular volume, epididymis is not really dilated or flat, then sometimes in this scenario, it can be helpful to do a diagnostic testicular biopsy if it's not meeting one of these categories very obviously. Now, on the other end of the spectrum, if the FSH is less than 7.5 or normal, and there's normal testicular volume, chances are it's going to be a blockage. Usually in this scenario, the most classical would be normal FSH, normal testicular volume, and typically a full epididymis, most likely obstructive, and you may have to do a reconstruction, a vaso-epi or something like that, or do further investigations into where the obstruction is. If the epididymis is normal or flat, then it can be a little bit less clear. If there's enough information pointing to still obstruction, then you'll investigate for reconstruction. If it's not clear, it's in the gray zone, then this is a common scenario that you might perform a diagnostic biopsy to make sure there's normal sperm production, or if there is not, then you'll have to consider sperm retrieval for non-obstructive azoospermia. So this can be a gray zone. And then certainly if the FSH is really low, barely detectable, and there's a flat epididymis. It could be a central or a pituitary hypothalamus problem, but more commonly in that scenario is if the FSH is undetectable or very low, the testicular volumes generally vary quite small. A couple cc's is the most common scenario if it's a congenital problem, and then that would be like I said, central NOA. A common scenario here might be like Kallman syndrome. If just going back to this other scenario, if the testicular volume is normal but FSH is barely detectable, LH is barely detectable, that's more commonly a scenario where there could be exogenous testosterone use. So the testicle is developed normally over time through puberty, so they have a normal volume, but now all of a sudden our hormones are very low and abnormal, and the testicular size won't totally shrink and atrophy. It will get a little bit smaller. There's no sperm production, but that could be more that type of scenario. So I'd ask the patient further questions about exogenous testosterone use, etc. Or there could be a central tumor, pituitary tumor, prolactinoma, something like that contributing. Now, if we are just in the normal range of FSH, full epididymis, like we mentioned, probably obstruction. If we have slightly lower testicular volume, but a full epididymis and the FSH is normal, then again, this is a little bit in that gray zone. And if it's not clear, this may be a situation where you're doing a diagnostic testicular biopsy. Okay. So another way to look at this, I find sometimes more helpful, is to look at this table. So this is a way that we break it into pre-testicular, so central, brain, hypothalamus or pituitary problems, testicular failure, or if there's a post-testicular problem, usually a blockage, or there's a problem with ejaculation or emission. And this is basically some of the findings that you would have based on all of the testing. So I'll just give you a second here if you want to take a screenshot or take a photo of this. This can be, handy just to have in your back pocket, but it's just a summary of everything we've explained over the last few slides, so I won't talk through all of it again. Okay, so now we'll transition to treatment of azoospermia. So first, central non-obstructive azoospermia, the medical treatment. So most often these are individuals with very small testes, nearly undetectable LH, FSH, or testosterone. Other tests, LH we would add on, prolactin, see if they have a prolactinoma. Sometimes we may consider a head MRI if there's a hypothalamic or pituitary abnormality. That's a potential. In terms of management, once there's fertility desired, there's a lot of different ways that we can go about this. I would say one of the more common scenarios is that you would give them HCG injections, and you give them 1,000 to 2,500 units intramuscular or sub-Q 3 times a week, which would be a common starting dose, but you could go up to 3,000 or 3,500 units 3 times per week. I've read as high as 5,000. I've never gone over 3,500 myself. It seems to be typically adequate to get the testosterone levels up and generate intratesticular testosterone. That is the key of what is happening here. HCG is acting in place of LH to stimulate the Leydig cells at the alpha subunit to stimulate testosterone production in the testicles. Now, I would generally start this for 3 to 6 months and retest the semen the first time 3 months later, and then usually monthly thereafter to see if we're generating sperm. If after 6 months we're not having any success, I will continue to use this, but then I'll consider adding either HMG or recombinant FSH. Recombinant FSH would be the most physiologic and pure and consistent, but it's much more expensive. But if we do this, it'd be 75 to 150 units twice a week injections. So that would be the most common algorithms for treatment there. Certainly theoretically, if it's a situation of like Kallman syndrome and there's a problem with GnRH, release from the hypothalamus, you could consider doing pulsatile GnRH injections. But you basically have to either be familiar with this yourself or have an endocrinologist that has the abilities to help set this up. And that's often less accessible in my experience. So this is both expensive and a little bit more logistically challenging. So I would say most people are using HCG injections, like I said, for about 6 months. Oftentimes they'll get success. If they don't get success, then addition of recombinant FSH alongside HCG or HMG. Now, like I mentioned, I'd follow the testosterone monthly in the beginning while I'm adjusting the dose of the HCG. And if the testosterone is still low, then I'll increase the dose until we're right in the middle of the normal range. You can do this by taking the trough level, so taking the testosterone the morning before an injection. As I mentioned, I would expect to see a sperm hopefully within 6 months, but it can take longer, certainly. But overall, if you take use one of these algorithms, you can eventually achieve having sperm in the ejaculate, at least some sperm, in up to about 85% of cases with a central cause of non-obstructive azoospermia. Now, if they haven't achieved any sperm after 6 to 12 months of this medical therapy, you can continue them on the medical therapy and consider a microtesty to find very rare sperm. But certainly I would leave this until you've given them a very good chance with just medical therapy alone. Yes. Now, so that was the pretesticular. Now we're looking at testicular dysfunction, so testis failure. This is the hypo testosterone scenario, so hypergonadotropic, hypogonadism, non-obstructive azoospermia. This is the most common form of non-obstructive azoospermia. Unfortunately, we only know the cause in maybe about 15% of cases. Like I was mentioning earlier, Klinefelter syndrome is most common, makes up about 7%. And then Y chromosome microdeletions make up the other 6%. And then there's different rare karyotype abnormalities or single gene deletions or mutations or abnormalities that have been described that make up the final, roughly 1 or 2%. So here we have no sperm. The FSH is usually high. I don't pay too much attention to how high the FSH is. If it's elevated, it could be 10, it could be 60 or 70. There's conflicting evidence in the literature as to the role of FSH as a predictive factor for being able to find sperm. So some series say it does not matter, and some series say FSH is positively predictive. So higher FSH, there's a better chance of getting sperm, and some say higher FSH, there's a lower chance of finding sperm. So I don't look at FSH as a detrimental factor, but it's more of a diagnostic clue of telling us what's going on. It's saying that the hypothalamus and the pituitary are compensating or trying to compensate for the testicle that is not functioning properly. Okay. Usually these individuals also have smaller testes on exam, especially if this is a congenital scenario and they didn't have an acquired cause of testicular failure, like with chemotherapy or radiation therapy, where they may still have close to normal sized testes. We're performing these genetic tests, as we mentioned, and typically here the treatment is a surgical sperm retrieval or a microtesty, which is the most commonly used. Certainly, patients should be aware that they can use donor sperm or undergo adoption. Now, if we look histologically, we can break down testicular failure type of NOA into these 4 different subclasses. So this is what normal looks like. Just briefly, this is the seminiferous tubule. Lining the seminiferous tubules are these myoid cells that help contract and create a basement membrane for the tubule. Just on the inside, still outside the blood testis barrier, are spermatogonial stem cells. Then there are Sertoli cells throughout. They have the prominent nucleolus within the nucleus, and they create the blood testis barrier, and they are really the main supporting cells of spermatogenesis. All the germ cells have cytoplasmic connections with the Sertoli cell. The Sertoli cell are depositing vesicles of signaling factors, growth factors, metabolic support to the developing and differentiating germ cells. And then eventually the germ cells differentiate. They undergo mitosis 1, mitosis 1, meiosis 2, and then spermiogenesis to arrive at the sperm on the inside. And then, of course, in between the tubules, you have your Leydig cells that produce the testosterone and other important cell signaling factors. And then there's also some progenitor cells out here. There are some macrophages and then microvasculature. So that's what normal looks like. In NOA, or testicular failure here, we can grade it. There's a few different ways of grading it. We can use a Johnson system, or we can categorize them into bins that we've done here. Hypospermatogenesis is the least severe. So this just reflects that there is full spermatogenesis present. So all the cells, all the way up to a full-grown sperm, but it's very, very inefficient. So oftentimes, many of the cells don't have spermatogenesis present, but there may be a few sperm present per tubule compared to tens to hundreds in a regular tubule. Now, maturation arrest can occur, meaning that the germ cells have differentiated up to a certain point and then stopped differentiating. And this can be late in the maturation process, so it could be at around spermatid after meiosis, and then no longer differentiate and mature, or it can be earlier during meiosis or prior to meiosis, where we only have spermatogonial stem cells, or in this case, there's actually some spermatocytes here that you can see. And then finally, Sertoli cell only syndrome is classically described as only Sertoli cells within the tubes with no signs of spermatogonial stem cells or any germ cell whatsoever. This is the most common histologic category that we see. And this is important in terms of the chance of success in finding sperm. So if we have this histologic diagnosis, we have about 90% chance. Maturation arrest, depending, we're somewhere around 40 to 50%. And then Sertoli cell only about 25% chance. Although knowing all of this, the other important concept here is that this may be the majority of the testicle, but there is heterogeneity or variability of what we see within the whole testicle. And it's that concept that there's variability amongst tubule to tubule to tubule within the testicle is what allows us to potentially have a successful sperm retrieval with microtesty. Okay, so I'll talk a little bit about microtesty and it'll make a little more sense. But basically, a microtesty, what we do is we deliver the testicle, we make an equatorial incision, we split it open like, splitting open a coconut. And we're looking through all of these seminiferous tubules under an operating microscope. And we're basically searching for dilated tubules like this, demarcated by the blue arrows. So these look a little bit healthier, a little bit more plump, and we believe it's reflecting that there are more cells present or a greater stage of spermatogenesis within these tubes compared to these ones, for example, that are very thin, atrophic, and likely don't contain very many cells. So during this process, we will harvest these areas with better looking and more healthy tubules in hopes of finding very, very rare sperm. So as I was mentioning, the chance of sperm retrieval varies depending on what the underlying histologic pathology looks like. The only tricky part is usually we don't have a diagnostic biopsy prior to doing the microtesty to use that information to inform the patient. But oftentimes I will many people do a diagnostic biopsy at the time, so we know exactly what the pathology looks like. Now, if this pathology was homogeneous and exactly the same throughout the entire testicle, then we would never find any sperm in any of these except for hypospermatogenesis. But what we know is that there is heterogeneity, and that is exactly the feature that we are taking advantage of in doing the microtesty, is finding these rare areas that there may be focal spermatogenesis and trying to harvest them. Now, some of the information that we will have ahead of time are some of the genetic diagnoses. So if they are diagnosed with Klinefelter syndrome, there's some variability in literature, but we'll have a positive sperm retrieval in about 48 to 66%. And if they have an AZF-C deletion, we're looking at 75%, and then nothing in A or B. Okay. And the overall average sperm retrieval rate is about 55%. Now, in Klinefelter syndrome, as we mentioned, there's an addition of one X chromosome, occurs in about 1 in 600 men. It's the most common feature or genetic diagnosis associated with azoospermia. The actual phenotype and clinical features and characteristics can be quite variable, but most of them have some degree of testicular dysfunction. Many of them have reduced testosterone production, and many of them have reduced fertility. The other important thing to know, there's a lot of text here, but just under 10% of these men will have sperm found in their semen. But for the other 92%, they won't have any sperm, so they'll be azoospermic, and therefore they will be more interested in microtesty or surgical sperm retrieval. So amongst those individuals, 45% of them will have sperm retrieved for IVF. And then if we look at IVF-ICSI outcomes for pregnancy and live birth rates, they're roughly around 43%, looking at some of the meta-analyses. Now, despite the individuals having an extra chromosome, the actual aneuploidy rates of the sperm are very close to what we find in the general population. So they range anywhere between 0.1 and 6%. So yeah, basically they don't carry a significant risk of passing on chromosomal abnormalities to their children. We'll just wrap up. See, are we just getting close to question time there, Dr. Bedaiwy?
Yeah, yes, we are.
Okay, great. I'll just wrap up this azoospermia section, and then that's a good natural finish point. We've talked largely about the hormone medications already, so that's just the final section. So this is just the Y chromosome, and like I mentioned previously, there can be some deletions in the A, B, and C regions. C, complete deletion C, is the only region that we can actually find sperm with. So of those with AZF-C deletions, the chance of finding sperm is about 47% for microtestes, and this gives us a fertilization rate of about 60%, and ultimately the live birth rate of about 23%. The other thing to know about AZF-C deletions is about just under 40% will still have some sperm in their ejaculate, and if they do have it, they would recommend to freeze it, cryopreserve it as a backup. But amongst the others, they do need to undergo the microtestes and surgical sperm retrievals. Last few slides here, ejaculatory duct obstructions. As we mentioned, they present with low volume azoospermia. They have an acidic or low pH and absent fructose. On transrectal ultrasound, usually you'll see a little cyst or dilation of the ducts or dilation of the seminal vesicles. And if this is the case, then we'll typically perform a transurethral section of the prostate, right of the ejaculatory duct specifically, and that will hopefully unroof it. And in the vast majority, they'll have return of some sperm into the semen, but there is a chance that it may re-obstruct. So usually we'll recommend to cryopreserve any sperm that do come. And typically I'll perform this in real time with ultrasound guidance to ensure that we don't resect too deep and make a rectal injury. Certainly on the obstructive azoospermia side, there can be obstruction in the vas deferens or the epididymis beyond the ejaculatory duct. About 15% of scrotal or inguinal surgeries can result in this incidentally, and it's important to recognize that when we can. Usually the volume will be normal if there's an epididymal or basal obstruction, and the FSH and hormone profile will also be normal. So typically, most subspecialists are performing a multi-layered vasovasostomy when that's necessary using an operating microscope. And sometimes if there are asymmetries, one testicle is healthier than the other, or there's an epididymal obstruction on one side, but a patent abdominal vas, and then there's an inguinal obstruction of the vas on the other side, then the most sensible thing in that case is to do a cross VV. So you take the good testicle and epididymis and connect it to the contralateral abdominal vas, which is open, rather than performing two less potentially successful reconstructions. And you can also perform these intra-abdominally if necessary, if there's a internal ring inguinal hernia repair that's resulted in basal obstruction. And then finally, for epididymal obstructions, there's a few different techniques out there, but typically the live technique or the longitudinal intussuscepted technique is what we typically use, that has the highest patency rates. And success rates are pretty variable in the literature, just depending on surgeon experience, and range between 40 to 80% chance of having sperm back into the semen afterwards. And this is just some pictures of what it kind of looks like. Again, for primary epididymal obstruction, this may be related to epididymitis or some kind of trauma or surgery that has resulted in this, or sometimes after a vasectomy, there can be a secondary blockage due to pressure that has ruptured one of the tubules and then it has scarred down. So this is another viable but challenging surgical reconstruction. We've already talked about absence of the vas deferens, but certainly if there are no vas deferens on both sides, really our main option is to perform a surgical sperm retrieval, either with a needle using a PISA, so to the epididymis, or a small testicular biopsy. And in both cases, this has to be used for IVF ICSI. And as I've already mentioned about the CFTR testing and the ultrasounds. Just a last overview of different sperm retrieval techniques for obstructive azoospermia. So non-obstructive, we're doing a microtesty. For obstructive, we can use a needle through the skin to retrieve epididymal sperm. We can use a needle to the testicle to aspirate sperm. We can do a biopsy of the testicle to retrieve sperm called TESI, or we can do a microsurgical sperm retrieval from the epididymis, which often results in more sperm than a PISA, but requires generally a surgical suite or an operating microscope, so it can be a little bit more costly. And of course, with all these scenarios, the sperm can only be used for IVF ICSI. We mentioned this, and we'll just skip to the end because we've spoke about most of this already. And just in summary, history and physical exam for male infertility and semen analysis really direct most of the next steps. Female partner is always really, really important component to the overall clinical scenario and helps in our decision-making of what treatments we may offer. Hormone genetic testing can be indicated if sperm concentrations are less than 10 million for hormones, 5 million for genetics. And our role in treatment is largely around modifying reversible factors when they're present. And in specific scenarios, performing surgical repairs like varicocele repairs, sperm retrievals in obstructed cases or non-obstructive cases, or reconstructions when they're amenable. And in many circumstances, things like IVF ICSI can be a really great treatment for male factor infertility. So thank you very much. Hopefully we have some time for some questions here.
Well, thank you very much, Ryan, for a very comprehensive overview of this topic. And I just invite Professor Emad to start moderating the question part. Professor Emad.
Thanks, Dr. Ryan, for this comprehensive talk, in fact, which included nearly all the investigations and management for male infertility. But now we have some questions from the chat room and questions and answers. We have question from Professor Dr. Tariq Husseini about
دكتور عماد ممكن بعد إذنك تظبط كاميرا اللابتوب والنتورك عندك؟
الصوت واضح؟
تمام.
We have a question from Dr. Tariq Husseini about which sperm DNA damage techniques do you recommend? And this question is from Dr. Bedaiwy in assessment of sperm DNA damage to your center.
Good question. A lot of it's often limited to what's accessible. I think a COMET test would be a good one that has good data behind it. Tunnel tests I'm quite familiar with, and so if I was to start an andrology lab, I would be considering one of those two. Certainly, I think SCSA is at least quite available in North America, so that might be one of the more popular tests that's used. I think they're all quite reasonable. They give slightly different information because the way that the test is designed is slightly different, but there's no real strong evidence that one is far superior to the others. But based on the data, Alkaline Comet and Tunnel seem to perhaps perform slightly better than the others.
Okay. The second question is, in fact, a concern about hepatitis C treatment and its safety in terms of semen parameters. Hepatitis C antiviral treatment. Hepatitis C, in fact, is common in Egypt, and in fact, the antiviral treatment which we provide since less than 10 years have dramatically decreased the prevalence of the virus. But there are some concerns. Do you have some research about the safety or its effects on spermatogenesis?
And sorry, which class of medication is this?
Hepatitis C treatment, antiviral treatment, that like different
antiretroviral therapy.
Oh, right.
And like we use it a lot of antiretroviral here for HIV patients. So it's probably the same class of medication, but different options are used in Egypt for treatment of hepatitis C and B. Both of them are very prevalent in Egypt, but mainly Hep C. So I think Professor Emad questions about hepatitis C.
Yes, about safety and about if there are studies, USA or Canada, about its long-term effects even on male reproduction. If this is available.
It's a good question. I don't personally have any experience with any patients through my practice with that, so I'd probably have to look specifically into that and get back to you.
Okay. My question, and I noticed that you tried to send a message. In fact, this is a message about the semen analysis. This is for gynecologists. If a normal semen report is enough for telling a husband or a couple with infertility that there is no problem with a male output, we can go through to full list of female evaluation. Is that enough? A semen report of normal semen according to WHO criteria is if it's normal according to the reference value. Is that enough for the male, or as you said in the presentation, it should be a start for other evaluation? For example, if a male comes with a varicocele, clinical varicocele, and having a normal semen analysis, can we stop here and we consider varicocele as if it is not present, or should we proceed to another steps for evaluating the male, or even interfere or do varicocele My question.
Yeah, good question. I think it's always helpful to have a history performed just to see if there's any reversible factors on history, in addition to a normal semen analysis. Beyond that, I think a normal semen analysis, even in the presence of a varicocele, I probably would not recommend the varicocele treatment unless there were other indications or reasons to treat the varicocele, such as pain or discrepancy in testicular size, etc. But if the semen analysis parameters are normal, I generally do not treat the varicocele for the purposes of fertility.
Okay. Other questions about the effect of pus cells, which is in fact a controversy in its diagnosis and its effect on semen parameters. Cases of Azoospermia, increased pus cell count in semen, should be managed, or sometimes could be considered as a basic finding. Pus cells.
Sorry, I just didn't quite catch that.
Pus cells increase in semen.
Leukocytospermia, and when you find white blood cells.
What to do in that scenario? Yeah, it's a good question. So if they're usually the report that you'll get back is probably facility dependent. If you have increased white bloods, or if you have increased round cells, that could either be immature germ cells or it could be leukocytes. So usually you'd have to do a peroxidase test or something to differentiate them. And then if you get into having abnormal leukocytes or too many, the next step I would usually do is a urine analysis, urine culture, and semen culture, and test for sexually transmitted infections like gonorrhea, chlamydia. If all of those come back negative, then I find that's often a bit of a tricky scenario. I generally do not treat with empiric antibiotics unless there's a reason for outside of any clinical symptoms. They had clinical symptoms of, a subclinical infection. I would have to think and consider it. Outside of symptoms and outside of a positive culture, I would probably leave it. If one of the cultures came back positive, then I would treat based on the culture. Certainly there have been some people have looked at using 7 to 10 day course of doxycycline empirically, but I haven't gone down that pathway very often, as I find the same number of leukocytes still exists whether there's been empiric antibiotic treatment or not in most cases.
Another question about obesity, which is in fact a big question. It needs another presentation. Obese male with infertility, do you recommend a specific management regimen like certain hormones like anti-estrogen, aromatase inhibitors, or just the general management of lifestyle management?
Good question. It's often a little bit tricky. So I would consider doing a hormone profile. If the testosterone is low or estrogen is high, I would consider treatment with medications like an aromatase inhibitor, a selective estrogen receptor modulator, so like clomiphene and anastrozole, for example. But I'd only be using that in a specific scenario where there is a laboratory abnormality, so the testosterone is low or estrogen is high. But I would focus heavily on the lifestyle factors. That would be kind of the core of my recommendation. So, increase in exercise, whether it be aerobic or resistance training, better lifestyle choices from a food perspective. I usually recommend what's good for the heart is good for your testicles and for fertility. So whole foods, less processed foods, good sources of natural fat and omega-3s, I think are all quite good. Generally, I think those lifestyle changes are helpful. If there is a very large swing in weight, either up or down, there's been some data to suggest that can actually be harmful for the semen analysis parameters transiently during the change. But I think if there's a gradual improvement of those things due to exercise and better food choices, then that will be a positive. And certainly there's data to support that may help improve their chances of fertility and pregnancy.
Another question from Professor Dr. Tariq Husseini about the couples are undergoing X cycle with diagnosed or even suspect sperm DNA damage. Do you recommend a specific protocol? For example, we can return to the example of varicocele. If they are a couple with varicocele, a male with varicocele are coming for XC, do you recommend varicocelectomy before XC, or they have a diagnosed or laboratory test diagnosing or confirming the increase in sperm DNA? We can manage this problem in the IVF lab in terms of sperm selection techniques or clinically first.
Yeah, good question. So I think, so in this scenario, they've failed IVF once or more. There may be high DNA fragmentation and they may have a varicocele. Is that the scenario?
Yeah. Yes, scenario idiopathic sperm DNA damage, and it's another correctable factor or modifiable factor, and they are going to have an X cycle.
Okay. So yeah, if they've failed an XC cycle already, then I would consider a DNA fragmentation analysis and see what the number comes back at. If the number is high and they're going to undergo a second IVF cycle, then I would consider using testicular sperm. If they have a varicocele, it depends a little bit on the female age and how many children they're looking to have. If the female age is getting into the late 30s, then I may consider not recommending a varicocele repair because it'll, require at least 6 months to see the results. Varicocele repairs on average decrease DNA fragmentation rate by only a few percent. So if we're, quite high and abnormal, then we still may be abnormal even after the varicocele repair. That being said, if it's a woman of lower reproductive age that we have more time, there is some data from the meta-analyses that perhaps repair of the varicocele may ultimately result in a improved IVF or IUI success rate and pregnancy and live birth rates. So that would probably be part of my decision making is female age. Is it young and we have some time? Then let's try to optimize the male variables. If we do not have the luxury of time, then I might not manage the varicocele. But in both instances, I'd probably check the DNA fragmentation. If it's in the older female partner, then I'd do the DNA fragmentation up front, decide for testicular sperm or not. If it's in the younger couple and we're considering a varicocele repair, I may do the varicocele repair first, then test the DNA fragmentation. If still elevated, I may do a sperm retrieval and use it that way. If it is normalized or normal at that point, then I wouldn't use the testicular sperm.
So there's a very wide range of individualization, and in this case, I guess it depends not only whether there's a varicocele or not, but also the collective assessment of both couples, taking into consideration the female factors as well.
Absolutely.
But antioxidants can help, or you a little evidence in this area?
The evidence is pretty poor for antioxidants, specifically for DNA fragmentation, as well as for general improvement. Of the studies available, they're either equivocal or slight improvements, but oftentimes the trial design or the study design has a lot of limitations and some inherent biases. So I really interpret them with a grain of salt. The other challenging factor with it is there is so much variability from study to study in terms of what are the components in the supplements and the antioxidants. It's really hard to compare from trial to trial and lump them together. So overall, it's difficult to recommend them with any certainty of evidence. With the DNA fragmentation, there are some small studies that suggest perhaps there's a small statistically significant benefit, but likely not clinically significant. But there haven't been, to my knowledge, much in the line of human clinical trials of any size to make a strong recommendation.
Another question in case of retrograde ejaculation. Testicular sperm or ejaculate sperms from bladder after urinary alkalinization, which is better?
Testicular sperm or sperm from...
Or sperms retrieved from alkalinized urine in terms of success. I think invasiveness is a matter of concern.
I think, you know, in any scenario when you can do it less invasively and get it from the urine, that would probably be my first choice. And if you're going to the testicle, you're going to have to use IVF ICSI anyways. So most likely, if you can get it from the urine, you should be able to select out, you know, a healthy, happy-looking sperm that is, you know, has good motility, morphology, etc. So that would probably be my choice.
Do you have a successful IUI cycles with the alkalinized urine spent artificial insemination cycle with prostate semen from alkalinized urine, or just ICSI?
Yeah, you could do IUI. You could do intrauterine insemination from sperm retrieved from the urine as well. Yeah. You just, in that case particularly, I want to alkalinize the urine and then wash it immediately and get the urine off and put it in a sperm buffer media so the sperm is much happier.
Okay. Yeah. There are other questions from Varicocele. You know that the dilemma of Varicocele, subclinical Varicocele. Dr. Mohamed asking about there's still a rule for subclinical Varicocele and Varicocele in Azoospermia patients. Which terms tell me whenever to interfere, whenever a patient is Varicocele, for example, do genetic test first in azoospermic patient or functional azoospermic patient with Varicocele before deciding to varicocelectomy to him, or what else?
Good question.
Functional azoospermic, yes.
Okay. So for subclinical varicoceles, I generally don't offer a varicocele repair. There are a few small case series that suggest that there is some benefit with subclinical, and then there's other case series that do not suggest a benefit. So the data isn't strongly supportive of performing a varicocele repair if it's subclinical, only if it's clinically detectable. For the azoospermia condition, the new ASRM AUA guidelines in the United States do not recommend varicocele repairs in those. The data that I showed today from the meta-analyses suggests that there could be some improvement for, you know, either chance of sperm coming back to the semen after a varicocele repair in a azoospermic patient, or slightly increased chance of sperm retrieval. The information that's complicating in that is if you were to retest an individual with non-obstructive azoospermia repetitively, there would be about a 10% chance of finding sperm on one of the ejaculates at some point in time. Yeah, and that's pretty comparable to the numbers following varicocele repairs. So that's one of the arguments in the AUA ASRM guidelines which I agree with that. There are variabilities in the studies presenting on chances of sperm coming back to the semen or sperm retrieval with microtesty, and some of them report up to 40%, but it wouldn't be the average. So in that scenario, I would say unless the patient is particularly young and there is a long runway where we're not going to do any disservice in waiting 3 to 6 months, I probably would not offer it. And if they are particularly young, then I'd want to have an individual discussion with that patient and make sure we're looking at the actual realistic potential of it.
One last question because of time. It's just over from Professor Dr. Ala Mubashir.
It's past midnight in Egypt right now, so it's 15 minutes past midnight.
Just the last question about: do you recommend a prognostic test for the presence of sperm in non-obstructive azoospermia? This is a question from Professor Dr. Ala Mubashir. Before enrolling the patient to biopsy, especially in cases of atrophic state or expected to fail or not, like for example an inhibin BSA, or just enrolling them directly to microtesting?
Yeah, it's another really good question. I think that space may evolve a little bit over time as we get more data to support if inhibins have a good, strong prognostic value. There's a little bit of data currently. There's also a little bit of data looking at AMH to testosterone ratios. And that might also be helpful prognostically. Certainly, if there's the availability of a diagnostic biopsy for histology, I'll usually use that and adjust the prognosis that I'm quoting or the chances of sperm retrieval. If we have genetic tests from the karyotype or the Y microdeletion that has a certain rate, I'll adjust my prediction of sperm. So those are the ones I routinely use. I don't routinely use the inhibins. I'm looking into possibly incorporating and doing some research on that to see what the value is. So that may be something in the future that we use more regularly. There's certainly some work being done for biomarkers, some from Keith Jarvie's group in Toronto, I believe, looking at perhaps TEX 101 or TEX 111 to see what that is. I think that paper is coming out probably pretty soon. And then there's some papers coming out looking at microRNAs that are specific to germ cells. And there's some very early data to suggest looking at microRNAs in the semen that may be predictive of microtesty results. So maybe in the next 10 years, there will be more at our disposal, but currently right now, those are kind of some of the things that I use in counseling patients.
Many thanks. And thanks, Dr. Ryan, for this comprehensive presentation and answers that really will help us in changing even our decisions in many clinical cases. Any last question?
Yeah, with that note, I want to thank you, Emad, for excellent management of the question part of this discussion. We wish we have more time, but we're limited to the time that booked by Zoom. And I think Ryan also have a newborn at home he has to take care of, I guess. Ryan, thank you very much for such a comprehensive topic and for sharing some of the reading materials ahead of time. It was very informative, very evidence-based as expected. On the behalf of Dr. Emad and the organizers, I would like to thank you very much, and on behalf of Asyut University as well. And you have a wonderful day, everybody. And please remember, in 2 weeks from today, we will have another webinar. Rebecca Flicht from Cleveland, Ohio. She'll be joining us on a very interesting topic about fertility preservation, not necessarily in cancer patients, but also in everybody. where fertility preservation could be a consideration. So please mark your calendars and join us in 2 weeks from today, same time, around 10 p.m. Egypt time. I know people stay late in Ramadan, so it'll be a nice lecture after Taraweeh. Thank you, everybody, and you have a wonderful night.
Thank you, Dr. Bedaiwy. Thank you.
You're very welcome. Thank you
very much.